Hello everyone and welcome to our module on acid-base principles. The normal pH found in the plasma in the arteries of the human body is between 737 and 742, and it is very tightly controlled. And the reason for this is that all the proteins in the body are designed to work at this pH. So if the pH were allowed to get higher than this or lower than this, proteins would stop working and the body would fail. The two organs that are important for maintaining this pH are the lungs and the kidneys. The lungs excrete carbon dioxide and the kidneys excrete acid, which is protons, H plus ions, and they also produce bicarbonate, which we'll talk more about in a minute. Shown on this slide is the Henderson-Hasselbalch equation. And this equation can be used to estimate the pH of human plasma if you know the concentration of bicarbonate, which is HCO3 negative, and the partial pressure of carbon dioxide. Now, you're never going to be asked in a medical school exam to calculate the pH of human plasma, but what you do need to understand from this equation is that the pH is going to go up or down as the amount of bicarbonate changes and as the amount of carbon dioxide changes. And as we will talk about in this video, the bicarbonate concentration is controlled by the kidneys, and the partial pressure of carbon dioxide in the plasma is controlled by the lungs. Also important to recognize in this equation is that bicarbonate is in the numerator, so when it goes up, the pH goes up, and carbon dioxide is in the denominator, so when it goes up, pH goes down. If you don't want to remember the Henderson-Hasselbalch equation, you can also remember the carbon dioxide acid dissociation equation, which I've shown on the slide here. So once again, we see that the amount of H plus is going to vary with the amount of bicarbonate and carbon dioxide. And by this equation, if the carbon dioxide level goes up, it will drive the equation this way and increase the amount of acid, which will lower the pH. Conversely, if the amount of bicarbonate goes up, it will drive the equation that way and decrease the amount of acid. That will raise the pH. So you need to either remember the Henderson-Hasselbalch equation or this equation so that in your mind you can figure out what happens as carbon dioxide and bicarbonate concentrations change in the plasma. You need to know how those things affect the pH. The clinical test that's done to analyze the acid-base status of the body is the arterial blood gas. This is a picture of someone performing an arterial blood gas on the screen here. You will get to do this many times as a third-year student and as a trainee. What you do is you insert a needle into the radial artery and you draw a sample of arterial blood. You need arterial blood because you want to know what the carbon dioxide content is of blood before it has passed through tissues. Once it passes through tissues, the carbon dioxide content goes up and the pH changes. By measuring the arterial blood gas, you are sampling blood as it leaves the lungs and getting an assessment of the acid-base status of the body. And there are three numbers you get from an arterial blood gas that are important for the acid-base status of the body. The first one is the bicarbonate concentration. Normal is 22 to 26. The second number that you get is the partial pressure of carbon dioxide. Normal is 35 to 45. And finally, you get the pH. And as I told you before, a normal plasma pH is 737 to 742. And most people just remember these three numbers I've shown on the screen here, 24, 40, and 74. This is the middle of the range of normal for those three measurements. Acid-base disorders are what occurs when the acid level of the blood becomes too high or too low. So when we say someone has an acidosis or an alkalosis, we mean they have a disorder that's altering the level of hydrogen ions in the blood such that it's tending to make the blood more acidic or more alkalotic. When we say someone has acidemia or alkalemia, we mean that they have a high or low pH in the bloodstream. Now you might think that acidosis and acidemia go together and alkalosis and alkalemia go together. That's usually the case, but not always. Sometimes you can have an acidosis but not have acidemia if you have a mixed disorder. So for example, if an acidosis disorder and an alkalosis disorder were occurring at the same time. So usually when we're talking about acid-base balance, an acidemia means an acidosis is present, but there are some exceptions. And that's why I've gone through this terminology on the slide here. So I told you before that the pH of human plasma is tightly controlled because if the pH becomes too high or too low, it can disrupt the functions of the body. But now let's talk about some of the specific effects that occur when patients develop an acidosis. First of all, a severe acidosis can cause myocardial depression. It results in low contractility of the left ventricular myocardium, and these patients can develop hypotension and shock. They can have a very low BP, and for this reason, a severe acidosis is life-threatening. If patients develop a high carbon dioxide level, and this occurs in some forms of acidosis, this will cause cerebral vasodilation. It's very high yield to know this fact. Carbon dioxide is a major regulator of cerebral blood flow. It's a major cerebral autoregulator. So when the carbon dioxide level becomes high, the brain increases blood flow, and this can lead to high intracranial pressure and headaches. These are sometimes seen in patients who have a high carbon dioxide level and an acidosis. Acidosis of any cause can lead to hyperkalemia. This is because hydrogen ions are shifted into cells in exchange for potassium. Cells of the human body have exchangers by which potassium goes out and hydrogen ions go in. What this means is that if the concentration of hydrogen ions gets high, these will be pulled into cells and potassium will be pulled out of cells, and as a result, patients can develop hyperkalemia anytime they have an acidosis and a high level of hydrogen ions. And then finally, when blood becomes acidotic, it shifts the oxyhemoglobin dissociation curve to the right. I've shown this at the bottom of the screen here. I talk about this in detail in the video on hemoglobin in the pulmonary section. This is called the Bohr effect. The body interprets a low pH as meaning that there is a lot of metabolic activity because metabolism normally produces carbon dioxide and acid. So when the body detects that there's a low pH, it thinks there's lots of metabolic activity, and hemoglobin shifts to the right on the curve down here. This allows more oxygen to be released for metabolism. And then the effects of alkalosis are generally the opposite of those for acidosis. An alkalotic serum leads to cerebral vasoconstriction and a drop in cerebral blood flow. When the pH becomes high, this can lead to hypokalemia instead of hyperkalemia like we talked about for an acidosis. And alkalosis shifts the oxyhemoglobin dissociation curve to the left, the opposite of what you see in an acidosis. So acid-base disorders where the pH is either too high or too low, come in two flavors. Metabolic disorders are disorders where there's either too much or too little bicarbonate. So in a metabolic acidosis, the bicarbonate level is too low, and this will lead to a low pH. If you look at the Henderson-Hasselbalch equation at the bottom of the screen, bicarbonate is in the numerator. So when this number falls, pH over here will also fall and an acidosis will develop. Conversely, a metabolic alkalosis is when there is too much bicarbonate. Respiratory disorders are related to carbon dioxide, and carbon dioxide's in the denominator of the Henderson-Hasselbalch equation. So if there's too much CO2, this will raise this number here, and this will lower the pH by the Henderson-Hasselbalch equation. That is called a respiratory acidosis. In contrast, a respiratory alkalosis is where the carbon dioxide level is too low. So what you need to be able to do for the Step 1 exam and also in clinical practice is to solve acid-base problems. And in these problems, you will be given the pH, the carbon dioxide level, and the bicarbonate level of an arterial blood gas, and you will be asked, what is the underlying disorder? So that's what we're going to talk about in the next few slides. So the first step in solving acid-base problems is to check the pH. If the pH is less than 737, then an acidosis is present. If the pH is over 742, then an alkalosis is present. Second step, once you've determined whether an acidosis or alkalosis is present, is to check the bicarbonate and the carbon dioxide levels. Are they increased or decreased? And remember what I told you earlier, the normal bicarbonate level is 22 to 28. Most people just remember it as 24, that mid value. And the carbon dioxide level that is normal from an arterial blood gas is 35 to 45. Most people just remember it as 40. Once you've looked at the bicarbonate and the carbon dioxide levels, you can determine what type of acid-base disorder you have. If you have an acidosis and the bicarbonate level is low, then you have a metabolic acidosis. Remember again the Henderson-Hasselbalch equation, when the bicarbonate level becomes low, the pH will fall. If you have an acidosis and a high carbon dioxide level, then you have a respiratory acidosis. Once again, carbon dioxide is in the denominator, therefore when its level goes up, the pH goes down. If you have an alkalosis and a high bicarbonate, you have a metabolic alkalosis, and if you have an alkalosis and a low carbon dioxide level, then you have a respiratory alkalosis. And finally, I've written the last two steps of solving acid-base problems on this slide. If you have a metabolic acidosis, you need to calculate the anion gap. I won't talk about that in this video, but I talk about it at length in the video on metabolic acidoses. And then finally, there are special formulas which can be used to check for a mixed disorder. Sometimes you can have a combined respiratory and metabolic disorder, or you can have two metabolic disorders like an acidosis and an alkalosis. These are complex acid-base problems, and we'll talk a little bit about these special formulas at the end of this video. Now we're going to talk about what is one of the most confusing aspects of acid-base physiology, and that has to do with what's known as compensatory changes. Acid-base physiology would be so much easier to understand if the bicarbonate went up or down while the carbon dioxide level stayed normal, or vice versa. But that is not the way it works. Bicarbonate and carbon dioxide are not independent of one another. When there's an abnormal bicarbonate level, the body will respond and modify the CO2 level so that the CO2 becomes abnormal as well. Conversely, if the CO2 level is abnormal, the body will respond by changing the bicarbonate level. This is called compensation, and because of compensation, in acid-base problems, both the bicarbonate and the carbon dioxide level are usually abnormal, and you need to figure out which one is the problem and which one is the compensatory response. So in a respiratory disorder, you have an abnormal carbon dioxide level. The compensation comes from the kidneys and the modification of the bicarbonate level. In contrast, in a metabolic disorder, you have an abnormal bicarbonate level like we talked about before. The compensation comes from the lungs. This is called respiratory compensation, and this is a modification of the carbon dioxide level. So on this slide, I've listed the 4 acid-base disorders and the primary abnormality and the physiologic compensation. The 4 acid-base disorders are metabolic acidosis and alkalosis and respiratory acidosis and alkalosis. So in metabolic acidosis or alkalosis, the primary abnormality is bicarbonate. We talked about this before. Therefore, the compensation is in carbon dioxide, and the compensation makes sense if you know the Henderson-Hasselbalch equation. So let's look at a metabolic acidosis. In a metabolic acidosis, the bicarbonate level falls, which will lower the pH. Well, the body wants to restore the pH to normal as much as possible, so in order to do that, what it's going to do is lower the CO2 level. The lungs are going to blow off more CO2. So the compensatory response makes sense because it attempts to normalize the pH and counteract the process that's going on. In contrast, in a metabolic alkalosis, the primary problem is a high bicarbonate and the compensation is high CO2. In respiratory disorders, the primary problem is carbon dioxide, so the compensation is with bicarbonate. And once again, the compensation will be either an increase in bicarbonate or a decrease, all determined by the Henderson-Hasselbalch equation and the goal of normalizing the pH. So the bottom line here, and the reason that compensatory changes make acid-base problems so complex, is that in most acid-base disorders, the bicarbonate and the carbon dioxide are both abnormal. One is the culprit causing the disorder, the other is the compensatory change. The easiest way to understand this is to go through a couple of examples, so let's do that now. First of all, let me point out that in simple acid-base disorders, meaning an acid-base disorder where there's only one disorder present, it's not a mixed disorder with multiple acid-base abnormalities. In simple disorders, the culprit and the compensatory change are both in the same direction. By this I mean that bicarbonate and carbon dioxide levels are either both increased or both decreased. You won't have one going up and the other going down in a simple disorder. So let's look at this example I've written here. Imagine a patient has a pH of 7.3. This is a low pH, so this is an acidosis. The bicarbonate level is low. That means this must be a metabolic acidosis because a low bicarbonate is only seen in a metabolic acidosis. It's not seen in a respiratory acidosis. Carbon dioxide level is also low. That is a compensatory change because a low carbon dioxide level would not cause an acidosis, it would cause an alkalosis. Therefore, what we have here is a metabolic acidosis with respiratory compensation. Both of the changes are low, meaning in the same direction, and that's what you see in simple acid-base disorders. And this all makes sense if you remember the Henderson-Hasselbalch equation that I've shown at the bottom of the screen. A low bicarbonate level will lower the pH, and that will cause an acidosis. A low carbon dioxide level will tend to raise the pH, and therefore that will counteract a acidosis. Here's a second example just to make this very clear. Once again, we have a pH of 7.3, which is low, so we have an acidosis. But this time the bicarbonate is high and the carbon dioxide is high. So this must be a respiratory acidosis because only a high carbon dioxide will cause an acidosis. A high bicarbonate will not. Therefore, the high bicarbonate must be the metabolic compensation. So what we have here is a respiratory acidosis with metabolic compensation. So now let's talk about how specifically the body compensates for acid-base disorders. Respiratory compensation always involves either hyperventilation or hypoventilation with the goal of modifying the carbon dioxide level. Respiratory compensation is the physiologic response to metabolic disorders where the bicarbonate level is abnormal. And one point I want to emphasize here is that hyperventilation is the physiologic response to a metabolic acidosis. In particular, patients with severe metabolic acidosis can develop what's known as Kussmaul breathing. This is a deep, labored form of breathing as the lungs try to blow off carbon dioxide. This is seen in patients with severe diabetic ketoacidosis and other severe forms of acidosis, and this is all part of respiratory compensation and an attempt to modify the carbon dioxide level. So let's look at this in a little more detail. When the lungs hyperventilate, this blows off carbon dioxide and the plasma carbon dioxide level falls. There will be less hydrogen ions in the blood and therefore the pH will rise. And this all makes sense from the equations we talked about earlier in the video. When the body hyperventilates, the CO2 level falls and this raises the pH. This is to counteract a metabolic acidosis where the bicarbonate level is low. If you want to do it by this equation here, when the body decreases the carbon dioxide content of blood, it drives the equation this way and removes acid, and therefore the pH will climb. Hypoventilation does the opposite. It retains carbon dioxide, the plasma carbon dioxide level rises, there are more hydrogen ions in the blood, and therefore the pH will fall. In respiratory acid-base disorders, the compensation is renal, and it comes from the kidneys. So in a respiratory acidosis, excess protons will be filtered and secreted into the urine in order to eliminate acid from the body. In addition, the kidneys will compensate for the respiratory acidosis by reabsorbing all the bicarbonate that they can. And then in addition, the kidneys are capable of generating more bicarbonate. So through all three of these mechanisms, excreting acid, reabsorbing bicarbonate, and generating bicarbonate, the kidneys can respond to a respiratory acidosis. If you look at the Henderson-Hasselbalch equation on the screen here, when the pH becomes low from a respiratory acidosis, the kidneys are going to try and raise the amount of bicarbonate, and that will bring the pH back up towards normal. When there is a respiratory alkalosis, the reverse of the changes that you see in acidosis will occur, so the kidneys will excrete more bicarbonate and let the bicarbonate level in the plasma fall. Shown on this slide is what's known as an acid-base map. You can find these in physiology textbooks. These maps plot the arterial blood pH along the x-axis, the bicarbonate concentration on the y, and then there are crossing lines for the carbon dioxide level. For example, a normal PCO2 of 40 is here, a high value of 80 is here, and a low value of 20 is here. So you can use these maps if you know the pH, the bicarbonate, and the carbon dioxide level to figure out whether your patient falls within the normal range or whether they have an acid-base disorder. And you're sometimes shown these maps on exams and asked to determine what a patient with particular values has. And it's very easy to understand this map. You know what we've been talking about in the earlier part of this video. Any patient who has a pH above 7.4 on the x-axis is going to have an alkalosis. And you can see here are the alkalotic disorders high on the x-axis. Any patient with a pH below 7.4 is going to have an acidosis, and that's what you've got here. The acidoses are all down here at the bottom of the x-axis. If you look at the y-axis, a normal bicarbonate level is 24. Any patient with a low bicarbonate level who also has a low pH is going to have a metabolic acidosis, and that's what you find here. Any patient with a high bicarbonate level who has an acidosis is going to have a respiratory acidosis, which you find right here. So if you just know the principles we've talked about in the last few slides about what high and low bicarbonate causes in terms of acid-base disorders, then you can look at this slide and figure out any region, what it represents in terms of acid-base disorders. I'll finish this video by talking about mixed acid-base disorders. In a mixed disorder, there are two acid-base disorders present at the same time. For example, a metabolic acidosis and a respiratory acidosis, or a metabolic acidosis and a metabolic alkalosis, or sometimes there are two metabolic acidoses. And it turns out that mixed disorders actually occur in a number of common pathologic states. For example, patients with GI illness often have vomiting and diarrhea, and vomiting and diarrhea cause two different acid-base disorders. So the way that you can recognize a mixed disorder is present is by first determining the expected physiologic response, meaning the expected compensation. There are formulas that we'll talk about in a minute where you can determine the expected bicarbonate that should be present in a respiratory acid-base disorder as compensation. Or you can determine the expected CO2 that should be present to compensate for a metabolic disorder. If the actual value of bicarbonate or CO2 does not equal the expected value, that means there is a second disorder that is present. And one special sort of high-yield tip I will give you is that compensation back to a normal pH is very rare. If you see an acid-base disorder where the pH is normal, especially if it's right in the middle of the normal range at 7.4, there's almost always a mixed disorder present because respiratory or renal compensation rarely ever brings the pH back to normal. There are some exceptions where it can, but it almost never happens. So back to our discussion of how to recognize mixed acid-base disorders. If the actual value for carbon dioxide or bicarbonate does not equal the expected value based on compensation formulas, which we'll go through in a minute, then you know that you have a mixed acid-base disorder present. The next step is to determine what is abnormal. For example, is the CO2 higher than expected, or is the bicarbonate lower than expected? Once you figure this out, then the usual rules apply for determining what is the secondary disorder. If the CO2 level is high, the secondary disorder is a respiratory acidosis. If it's low, it's a respiratory alkalosis. If the bicarbonate is low, then you have a metabolic acidosis. If it's high, you have a metabolic alkalosis. So if you understand all that, now we can talk about the compensation formulas that you can use to calculate the expected carbon dioxide or the expected bicarbonate in the setting of an acidosis or alkalosis. The first one we'll talk about is Winter's formula. I've bolded this because this is the most important one to know for step 1. This one is very likely to come up on your exam. Other formulas that are less likely to come up on step 1 include the metabolic alkalosis formula, the acute and chronic respiratory equations, and then finally something called the delta-delta. This only pertains to metabolic acidoses, and I won't talk about it here, but I will talk about it in the video on metabolic acidoses. So when you have a metabolic acidosis, the compensatory response is a respiratory alkalosis, meaning a fall in carbon dioxide level, and this is achieved through hyperventilation. So Winter's formula allows you to calculate the expected carbon dioxide level in a metabolic acidosis. And as I told you before, if the actual carbon dioxide does not equal the expected, then there's a mixed disorder present. And this is Winter's formula at the bottom of the screen here. It says the expected carbon dioxide level is 1.5 times the bicarbonate level plus 8 plus or minus 2. The true carbon dioxide level should fall within this range predicted by Winter's formula unless there is a secondary disorder present. So this is easiest to understand if we just go through an example. Let's imagine we have a patient with a pH of 7.23. That's a low pH, so this is an acidosis. The bicarbonate level is 9, that's low, a normal value is 24, therefore we have a metabolic acidosis. The carbon dioxide level is 22, that is also low, the normal is 40. This means we have a metabolic acidosis with respiratory compensation. We now want to know if there is a second acid-base disorder present besides the metabolic acidosis, and to do that, we use Winter's formula to see if the actual CO2 matches the expected CO2. This is Winter's formula right here. If we plug in the values from the question, Winter's formula says the expected carbon dioxide level is 1.5 times 9 plus 8, which equals 22 plus or minus 2. And our actual carbon dioxide level falls within this range, it's 22. This means we do not have a secondary acid-base disorder present. We only have one disorder, and that is a metabolic acidosis with appropriate respiratory compensation. Here's another example. A pH is 7.10. That's a low pH, so this patient has an acidosis. The bicarbonate level is 12, which is reduced. Normal is 24, so this patient has a metabolic acidosis. The carbon dioxide level is 40, which is normal, so right away you know something's wrong. You should never have a normal carbon dioxide level in the setting of a metabolic acidosis, but that's what this patient has. So now we're going to use Winter's formula and determine the expected carbon dioxide level. The expected carbon dioxide level using the values in this example are 1.5 times 12 plus 8, which is 26 plus or minus 2. So what we've got here is a carbon dioxide level that is too high. It is above the expected value. So if the PO2 is above the expected value, there must be a concomitant respiratory acidosis, because respiratory acidoses are what cause the CO2 level to become high. So this patient has a metabolic acidosis with a concomitant respiratory acidosis. So that's Winter's formula. Now I will go through some of the other compensatory equations. In a metabolic alkalosis, there is a compensatory respiratory acidosis. This is a rise in the CO2 level caused by hypoventilation. And the equation to determine the expected PCO2 in a metabolic alkalosis is that there should be an increase of 0.7 millimeters of mercury of PCO2 for every 1 milliequivalent per liter increase in bicarbonate. This is shown in the equation at the bottom of the screen here. And once again, if the actual PCO2 does not equal the expected, then you have a mixed disorder. So let's go through an example. Imagine a patient has a pH of 7.48. That pH is high, so this is an alkalosis. The bicarbonate is 34, which is also high. Normal is 24, so this is a metabolic alkalosis. The carbon dioxide level is 47, which is high, and that makes sense. That's respiratory compensation for a metabolic alkalosis. So the change in bicarb from normal is 34, the actual bicarb value, minus 24, which is 10. So we have an increase of 10 milliequivalents per liter of bicarbonate. So we can now use this equation and say that for an increase of 10, the expected change in CO2 is 0.7 times 10, or 7. Our actual change in PCO2 is 47, the value we have, minus 40, a normal PCO2, which is 7. So our expected change in PCO2 matches the actual change in PCO2. Therefore, this is a simple metabolic alkalosis with no secondary disorder. Next, let's talk about the compensation for respiratory acidosis. I told you earlier that the kidneys can compensate for respiratory disorders by changing the amount of bicarbonate in the plasma, but what you need to understand is that that compensation takes a few days to occur. There is, however, a more minor compensation that happens acutely, and so therefore the compensation to respiratory acidosis comes in two forms. There's the acute change and then the chronic change by the kidneys. So if a person develops a respiratory acidosis acutely within a few minutes, there are intracellular buffers that will very slightly raise the serum bicarbonate. These are things like hemoglobin and other proteins that can bind a little bit of acid, and this will lead to a small change in the pH. If the respiratory acidosis continues, however, after a few days, the kidneys will start to generate more bicarbonate and raise the serum bicarbonate, and this will lead to a much more substantial rise in serum pH. So in patients with chronic respiratory disorders, there's a very significant change in the bicarbonate because the kidneys are involved. In patients who develop an acute respiratory acidosis, there's only a very small change because the only thing that can buffer the rise in protons is hemoglobin and other proteins. So here are the equations. The acute compensation equation is a rise of 1 in bicarbonate for every 10 rise in CO2. The chronic compensation is a rise of 3.5 in bicarbonate for every 10 in CO2. So let's go through an example. Imagine a patient has a pH of 7.1. This is an acidosis. Imagine the carbon dioxide level is 80. This is high, so this is a respiratory acidosis. Acutely, this will cause a change in bicarb of 40/10, which is 4. I got that from this equation right here. This will change the bicarbonate to 28, and if you plug that into the Henderson-Hasselbalch equation, the pH will rise from 7.1 to 7.17. So you get a small rise in pH from this acute compensation. The chronic change, however, will be 3.5 times 40/10, which is 14. I got that number from this equation here. This will lead to a bicarbonate of 38, which will cause the pH to rise to 7.3. So like I told you before, you don't need to know these equations for step 1, but what you should appreciate is that acutely you can only get a small increase in pH from the compensation to a respiratory acidosis. Chronically, once the kidneys start to work, you can get a much larger rise in pH because of the much larger rise in bicarbonate. Shown on this slide are the compensatory equations for respiratory alkalosis. Just like respiratory acidosis, there are acute and chronic compensatory formulas. The acute compensation is a change of 2 in bicarbonate for every 10 decrease in CO2. The chronic change is a change of 4 in bicarbonate for every 10 change in CO2. Let's go through an example. Imagine a patient has a pH of 7.7, that's an alkalosis. The PCO2 is 20, that's low compared to normal of 40, so this is a respiratory alkalosis. Acutely, the bicarbonate will change by 2 times 20/10 or 4. I got that from this equation right here. This will cause the bicarbonate to become 20 and give you a pH of 7.62, so a slight improvement from the initial pH of 7.7 down to 7.62. Chronically, the change will be 4 times 20/10, which is 8. I got that from this equation right here. This will cause the bicarbonate to become 16, which if you use the Henderson-Hasselbalch equation gives you a pH of 7.53. So once again, acutely, we had some change in the pH, but not as much as we get chronically once the kidneys begin to do their job. So I've mentioned this along the way, but I just want to emphasize this point that the compensation time frame is different for the lungs and the kidneys. Respiratory compensation to metabolic disorders occurs within minutes. The body can quickly change the respiratory rate to compensate for a metabolic acid-base disorder. In contrast, metabolic compensation from the kidneys takes time. There is that acute mild compensation in minutes, which occurs from buffers, but the chronic, more significant compensation comes from the kidneys, and this takes days to develop. So someone who has just developed a respiratory disorder will not have a large change in the bicarbonate. That person needs to have that disorder for a couple of days so the kidneys have time to respond. I'll finish with this summary slide. We have respiratory and metabolic acidoses. The compensation for a respiratory acidosis is an increase in the bicarbonate level, and you can use the acute and chronic formulas to determine if compensation is appropriate. For a metabolic acidosis, the compensation is a decrease in the carbon dioxide level, and that's where Winter's formula is used to determine whether the compensation is appropriate. For alkaloses, they're respiratory and metabolic. The compensation for a respiratory alkalosis is a decrease in the bicarbonate level, and there are acute and chronic formulas to determine if that compensation is appropriate. And then finally, in a metabolic alkalosis, the compensation is an increase in the carbon dioxide level, and there are formulas for the expected carbon dioxide change. And that concludes our video on acid-base principles.